Good afternoon, attendees. Good afternoon, speaker. On behalf of the Chief Health Treatment Undertaking Services, Professor Aisha Al-Dahiri and Dr. Leila Sheikh Ismail, the Chair and Co-Chair of Nutrition and Health Symposium Webinar Series NHS 2021, we are pleased to invite everyone to our today's second webinar series, which is entitled Obesity, Childhood Obesity, that will be given by Dr. Carla Habib Murad. Before we proceed, we would like to take this opportunity to thank our NHS partner for today's webinar, Spec Bright Group. They have a very interesting short topic with us later on that will be related to our today's webinar in their product InBody. Before we proceed as well with our webinar for today, we would like to remind everyone that as part of new Department of Health Abu Dhabi CME Certificate of Attendance Issuance Guideline, all UAE residents are required to request their certificates through DOH TAM online portal, which you will receive the step-by-step process from us within 24 hours after this webinar. Please make sure that you will request the title for today's webinar, as the approval will come from DOH after we submit the attendee list. Furthermore, for international attendees, we will be the one to provide you the certificates after complying with the required process, which everyone will receive through Zoom. We would like also to invite everyone to follow, like, and subscribe our social media accounts, Facebook, Twitter, Instagram, LinkedIn, and YouTube under the Chief Health Treatment Undertaking Services to receive further announcement of our upcoming courses, as well as view the previous recorded sessions, and as well as our recorded session for today. Without further ado, we are pleased to introduce to you our speaker, Dr. Carla Habib Murad, live from Lebanon, who will inspire us with her topic for today. Dr. Carla, we welcome you, and the floor is yours.
Thank you, Kim, and welcome to everyone. I'm really happy to be with you today. We're going to discuss in details what should be done, what can be done, what is being done also related to pediatric obesity. And we all know that this is not just one hand clapping, it's a team effort, and we are going to discuss this in details. But before I start, I would like to know a little bit, if you can type in the chat box, what are your careers or your majors, if you're students, you are in which health profession or in which health career, so that we know a little bit who is our audience today. So dietetics, yes, welcome everyone. Okay. Good. So this is, we have, yes. So welcome to all of you from University of Sharjah, from Lebanon. Okay. Nurse, dietitian and nurse. Wow, that's a good combination actually. Great. Great, thank you. Ahlan wa sahlan, pediatric doctor, thank you. From Egypt. Also from Egypt, thank you. Thank you all for joining again. So I'm going to share my screen. And you will see if all is well. So let me know if all is clear, Kim.
Yes, Dr. Carla, all is clear.
Great, great. So when we start talking about childhood obesity, of course, we are going to cover several aspects. I'm going to talk about, of course, the prevalence worldwide, and of course, in the region. We will show a little bit around the region. I'm going to talk about how we define obesity, its consequences on health. What are the factors causing childhood obesity? What are the different levels of prevention and treatment? And then with some concluding remarks. I would like you to be as much involved as possible. If you have questions, please type in the chat box. We'll get to this at the end, and we'll have some breaks all along where we also can chat and have some discussions. So now we know that obesity is a global epidemic. We have talked about this a lot during the past decade. And when we're talking about health problems or serious public health challenges, obesity would rank among the most in this 21st century. And now the problem is that even low to middle income countries are affected by this due to many causes, mainly in urban settings. Now, when we see the prevalence, it has increased at an alarming rate, and it has reached in developing countries epidemic levels. So this is not a joke anymore. So when we look at worldwide, we see that it has tripled since 1975. So when we look at adults, almost 2 billion adults 18 years and above were overweight in 2016. And of these, 650 million were obese. When it comes to children aged 5 to 19, over 340 million children and adolescents were either overweight or obese. And in 2020, 39 million children under the age of 5 were either overweight or obese. Now, if you look at this map, it is scary, because when you see when you look at this 10% of children under 5 with overweight or with obesity, we have at least 3 sub-regions with those numbers. So this is the dark purple, whether it's in North Africa, Central Asia, and Southern Africa. Now, I'm going to show you in the, when we're talking, of course, in estimation, this is around 42 million children under 5 with overweight or obesity. And when we look at the charts and the prevalence, how it's changing, we notice that in certain countries, for example, in, I would say, maybe Latin America, or I would say certain parts of Europe, whether it's preschoolers, children or adolescents, we see that there are some leveling of, when we're talking maybe preschool children, of the obesity. So even if we see a level of in terms of overweight or obesity, the prevalence is still high. So it's good that it stopped increasing in certain countries, which is not the case everywhere. So when you see in the Middle East and North Africa, that's it was around 21% in 2000, reached 33% in, and we're talking here about children, in 2016. So we haven't reached yet in our region the leveling of in terms of prevalence, whereas we have seen it a little bit in certain areas in Europe or in the United States. Now, when we're talking again predictions, the numbers are not the numbers are scary. The issue is that obesity is preventable, and we definitely need to do something about that. We are many in the health profession that should be working around this, and what can be done or what should be done. So, but first, let's see how do we actually define obesity, overweight or obesity, which is an abnormal, we agree on that it's an abnormal or excessive fat accumulation. And that fat accumulation is a risk for diseases. So when we're talking overweight or obesity, it's not a matter of aesthetics. We're talking about risk for chronic diseases, especially when it comes to also pediatric obesity. On top of this, it is a public health problem that affects the quality of life. It, of course, increases the risk of illnesses and on top of all, it raises healthcare costs. And now, in all parts of the world, and now, especially in our area, we are looking at ways to cut down on healthcare costs through, of course, prevention. Now, if you want to talk about measurements, I'm sure that most of you are familiar with the body mass index, which is I would say, the most common measure of adiposity, and it has a good correlation with body fat. It is easy, low cost, non-invasive method or measure to use in the community, in the clinic, in the schools, in most setups. Now, on top of the BMI, we also look at the waist circumference, and we'll talk a little bit about waist circumference when it comes to use it with children, especially in terms of cutoff points. Now, so the definition, as many of you know, of the body mass index is the weight in kilograms divided by the square of the height in meters. And for children and teens and teenagers, we have BMI age and sex specific. So I'm going to show you or talk about two BMI classifications. The first one is the BMI for age weight status according to percentiles. And this is, of course, based on expert committee recommendations, the CDC. It's mostly used in the United States. And those are the percentile ranges. Now, this is, again, a good, I would say, a tool to be used in clinical settings, also in I would say in research as well. And however, one drawback for percentiles is that until now it's reaching the 97th percentile, which is, I mean, it gives us correlations with diseases. So studies have shown that a BMI above the 95th percentile gives a correlation or is related to health risk diseases. Now, in these, we don't have above the 97th percentile, and now this tool is being updated so that we have the 99th percentile, which actually would lead into or takes us into the adult BMI classifications. Again, this is, as I said, age and gender specific, and used mainly also in the United States. We use more in our region, and actually more and more, not just in the region, worldwide, for clinical studies, for research, and in the clinic, the BMI based on the Z-scores. This is a good alternative, and as I said, is widely used. Now, the BMI in this tool actually is, so the BMI of the child, which is transformed into the number of standard deviations above the mean or above or below the population mean. So each standard deviation above or below the standard mean of the population will tell us if the child is underweight, child with overweight, or child with obesity. The standard deviations, or the BMI based on the standard deviation, is a very good tool because it offers additional information about metabolic and cardiovascular disease risks. For example, if we have half or 0.5 point decrease in the standard deviation for a child in a given amount of, let's say, between 6 to 12 months, this is significantly correlated with a decrease in body fatness. And when we look at specifically BMI for BMI for age, girls, boys, based on the Z-scores, you see that we need to plot the age in years and months. So this is even more specific as compared to the percentiles. Again, of course, we have for different ages and different genders. So before we move on, just a few words about the Western Conference, which actually tells us about the obesity or the abdominal adiposity, and it offers additional information, especially when we are looking at prevention from metabolic risk factors, cardiovascular disease factors, and a Western Conference above the 90th percentile for age and sex is again correlated with diseases. Now, there are still research, and we're still looking, or scientists are still looking at the exact cutoff points for Western Conference and updating these cutoff points. Now, if we move to the consequences of obesity, again, we are all familiar with all these non-communicable diseases that we actually see in the clinic for those of us who have started practicing, and we are looking at cases of type 2 diabetes, cardiovascular diseases at a very young age. And I myself have to deal on regular basis with children with overweight, and at the same time type 2 diabetes, or actually I would say sleep apnea and other illnesses. And also studies are clear about it. Children with obesity will have their obesity and disease risk factors will be even greater when they reach adulthood. So just one comment, and this is a special concern recently, and that is child obesity hypertension. We have talked a lot about child obesity or children with obesity and type 2 diabetes, but now we're shedding the light on childhood obesity hypertension, and we have seen that compared with children who have a healthy weight, children with obesity have double the risk of incidence of hypertension. And children with severe obesity, and here we're talking a BMI for age above the 3 or above 2 standard deviation, have 4-fold increased risk of incident hypertension. So now we are worried that with the prevalence of obesity that is still increasing in certain countries, hypertension specifically, but also the associated risk factors such as, for example, cardiorenal diseases will increase unless we have strategies to actually prevent and treat obesity as it starts developing. Again, we should not forget that childhood obesity is also related to psychological problems, among which anxiety and depression, a decreased self-esteem. Children with obesity also have shown to have a lower self-reported quality of life. We are facing stigmas, social stigmas such as bullying in schools, even within the family. Children with obesity, children overweight do suffer from stigmas and bullying. Some studies also have indicated a little bit of poor academic performance with a lower quality of life experienced by the child with overweight or obesity. Now let's have a small stop and let me hear from you. We're going to have our first poll question, and I would like to hear from you. What do you think is the major or the chief factor affecting childhood obesity? Is it heredity, the environment, or the physical activity? So according to you, what is the chief factor affecting childhood obesity? So we have 20% heredity, environment 60%, physical activity 18%. Are we done? Did everyone vote, Kim?
Yes, Dr. Carla.
Yes. So actually, I would say that the chief factor for obesity is genetics. This is the number one cause of childhood obesity, but this does not mean that the environment is not one of the major factors affecting childhood obesity. And actually, when we look at what actually causes the fundamental cause of pediatric obesity, that's specifically an imbalance between energy intake and calories expended. Now, we all have seen the increase in the consumption, the shift actually towards an increased consumption of high energy dense food and snacks, large portion sizes, of course, food and snacks that are rich in added sugars, added fats. At the same time, a notable decrease in physical activity, not just as leisure, but also decreased physical education and recess time at school. So children are moving even less at school, on top of course, the availability of high energy dense foods and beverages. And we should not forget the problem with sedentarity. So it's not enough to ask a child to move an hour a day when he's sitting 10 hours a day. So increased screen time is also an issue. And again, when we're talking causes, factors that affect, we should not forget the macro level environmental factors, which is related to cultural, socio-etal changes, and of course, anything related to the food and beverage industry that influences food choices, food marketing, and national policies that affect the child and the child's environment. So again, when we look at factors or food choices that our children have at school, this is an important problem to tackle. Food portions, again, is in our culture, as if we're talking in the culture, meaning in our Arab culture, and the abundance of food, a bigger portion is always the choice. And certain, of course, habits in food consumption during the day that our children and teens are acquiring. Now, I have to talk a little bit of some wrong perceptions that are still persisting. I never thought that I would still have to mention this. I personally in the clinic also face, of course, parents that are aware of this childhood obesity problem as an issue for health, but we still face in many countries misconceptions about a child being the more, I would say, a child with an overweight as looking healthy. I think that you might face this, or you do face this in your personal in work or at workplace, where it's okay if he is a little bit overweight, but we would worry more if the child is underweight. So I'm not sure if you agree with me on on this perception. And then we also have this idea to fight with parents who think that the child, of course, would grow, but sometimes growing up with in an environment such as where we live, growing up without preventing all these factors affecting our children, the fact that the weight will not go away. However, we're going to talk about all these details in a bit with the prevention and treatment approach. And actually, when we talk prevention and treatment of pediatric overweight or obesity, this requires a system level approach that include, of course, the skills of a registered dietitian, but not alone. The registered dietitian should be within a team and working together, and we'll see how this will give actually tremendous results and better results, of course, in terms of prevention and treatment. So in this context, the holistic approach every time is the key, whether we're talking prevention in the community, whether we're talking about behavioral changes, or whether we're talking about specific dietary approaches. So I'm going to walk you through the steps or the stages that have shown to be most effective actually in changing or in preventing pediatric obesity. And we will start by what we call the primary prevention. And this is actually aimed at all the population. And we're talking specifically about programs that mainly would prevent the incidence of overweight and obesity and support an environment for weight maintenance. These these strategies should mainly be performed in the community, usually in schools, and of course these can be in healthcare facilities. These can be in preschool settings and in any setting where there is a care for children. The secondary prevention stage is mostly aimed to overweight or obese youth with no weight-related comorbidities, and these are more structured programs that help us actually reach a healthy weight. They may require medical supervision, and again, in both primary prevention and secondary prevention, we need both a team with a registered dietitian, the presence of also a nurse, especially if we're talking, we're working in school environments, and of course, whenever possible, referral to a medical supervision. Finally, the tertiary prevention, where it is specifically aimed at overweight or obese children with overweight or obesity with comorbidities, or we would talk about obese youth with severe obesity, and these are intensive, comprehensive treatments conducted under medical supervision with the aim to resolve comorbidities. Again, this is related to weight management, of course, with a multidisciplinary team, but it might include the use of pharmacological treatments or surgeries. I'm going to walk you through those stages and just in summary, see which works best and what are the mostly, I would say, the strategies that worked best. If we start with the primary and secondary prevention strategies or stages, for example, in schools or in childcare settings, the most successful ones are those that integrated education along with a supportive environmental change. So we're talking about children being taught about healthy eating, about physical activity. So at the same time, we are educating the children and helping them achieve a behavior change, along with, of course, behavior changes in terms of nutrition and physical activity. Now, the most successful ones were those that included both nutrition and physical activity as part of the intervention. Studies or interventions that were only targeting physical activity did not seem to give the same effectiveness, or were not as effective as the ones with nutrition education. Now, what proved to be successful in those interventions are the hands-on activities that included opportunities for tasting the food, touching, working with the food, such as preparing recipes. Actually, with children, we know that repeated exposures are necessary so that the child accepts new food, especially preschoolers. And the most important also component of those interventions were parental engagement, especially children who are preschoolers or in elementary school. Studies without parental engagement were not as successful as those with parental engagement when it comes to this age group, especially I would say preschoolers and primary school children. Of course, when we're talking in the school is not the only environment. So when I'm working in the school, I need to have a community engagement. So I would give you examples about interventions done in schools where there were policies to limit food availability and or actually present foods that are healthy at school. So there were policies for that. The child would go out of the school, find another shop at the door and buy whatever foods are available. So again, it's a holistic approach, not just the school, but also with the whole community. And when it comes to interventions, the dose is very important, and sustainability. So it's not a one-time intervention, a two-time intervention. It's a continuous intervention that should follow with the child along the years in schools, so that the change in behavior happens, because it's not an over time or overnight change, and also for sustainability. So I'm going to take a few moments to talk you through a study that you have done at the American University of Beirut. Actually, it's a 3-year obesity prevention program in Lebanese school children. So, of course, to work on healthy behaviors and BMI. The Ajal Salima program. And so just briefly, the program was for around 3 years, where 2 years had 2 years of intervention and 1 year washout period where we didn't have any intervention. The students for 2 years, the same students, were exposed to activities in the classroom where they learned about healthy eating, experienced recipes and food. There was a component to work with the food service at the school so that healthy foods are available, and a component with parents, engaging parents with the intervention to help changing behavior. So for the findings, also briefly, when it comes to the odds of being overweight or obesity, and we had public and private schools, we saw that there was almost a 50% or 52% decrease in the odds of overweight or obesity in children in the public schools. We didn't see this in private schools, specifically at the end of the study, so after the washout. So here we can say a delayed effect or a sustained effect after the 3 years of intervention. When we look at some determinants of behavioral change, such as knowledge scores, we notice at year 2 and at specifically at year 2 of intervention and at 1 year washout, there was almost a 3-point increase in knowledge scores, both in public and private schools, and this was sustained. This is good because when we came back to these students a year after the intervention had ended, the knowledge was still high. The improvement in knowledge. When we looked at specifically the odds ratios for directly post-intervention for different dietary intakes, we see that for the fruits and vegetables at 2 years of intervention, there was a significant increase in the intake of fruits, raw vegetables, a significant decrease in the intake of high energy dense foods such as chips, decreased intake of high energy dense beverages, soft drinks, but not sweet drinks. We'll explain a bit why. Again, after washout period, effect was mainly seen in the sustained effect for fruits, vegetables, chips was mainly seen in public schools. And why is that? That's because in public schools, there was a decree that had a policy where the school cannot offer, or there should only be healthy foods in the school shop, whereas in certain private schools, that was not the case. So the school shop was not abiding by the rules. And again, this program has been adopted by the Ministry of Education in Lebanon. So it was mandatory to have these sessions or this program all along in public schools, whereas it was not the case in public schools. So again, this is where we see the importance of having policy, again, helping out in reaching our goal in preventing overweight or obesity. Now, we have another poll question, and maybe after the poll question, we can maybe have a few chats as well. So according to you, the best diet plan for weight loss for children is a low-calorie diet, a high-protein diet, or none of the above? So none of the above. Good. So what do you suggest? Most of you have answered none of the above. So what do you suggest in the chat box? Physical activity? Yes. Lifestyle changes? Okay. Controlling snacks intake? Okay. Okay, so holistic approaches, control screen time, the three of them. Okay, healthy food and physical activity. Okay, adequate meals, balanced meals. Okay. So healthy, balanced meals, controlling snacks. Okay, okay. No fast food, yes. Okay, of course, lifestyle changes. Okay. Good, so actually you would you would recommend, what would you recommend? And here we're talking about the tertiary stage prevention, where we need to help the child at least, I mean, this is now a more targeted approach where we have to meet the child in the clinic. We need supervision with the medical supervision, especially if we are facing a child with comorbidities. Now, what proved to be really effective in terms of dietary approaches are the ones with multiple components. So where we're not talking only about nutrition and physical activity component. Again, parental support here is a must, with, as you have all mentioned in the chat box, behavioral strategies for healthy lifestyle changes. So what actually, what can be done, or what should be done in the clinic per se, of course, the usual BMI calculations, comparing with growth charts to determine the stage of obesity, lipid biochemical assessments, whether blood tests for lipid profile, sugar profile, etc., and a thorough 24-hour recall diets to be able to give recommendations. Now, again, when we're talking visits or clinic visits, monthly office visits are recommended. If this is a burden on the child or his parents, then we would recommend maybe every 2 or 3 months. But this should be regular, and I mean, parents should understand this. However, we might need, and mostly this is very helpful, we might need the help of a counselor, mainly to help parents with parenting skills, resolving family conflicts, or give motivation. Again, in the clinic, we face a lot of issues, concerns with how parents deal with their children. Either parents are too restrictive or at the same time too permissive. So there is a certain, I would say, midpoint where, I mean, parents cannot, they would need guidance in terms of dealing with children and their food. Many times we also need to refer the children with obesity to a physical or exercise therapist, because some children might need, and families might need, to develop physical activity habits. So sometimes you would need to actually teach them what to do, how to do, where to find ways to exercise, where to go. It's not just easy. I mean, you could tell people, okay, go for a walk for 45 minutes, and then they might end up just not doing this. And as you have all said, physical activity is very important in the treatment of children with overweight or obesity. Again, we need to help parents or train them on how to improve their home environments. There are, again, depending on the culture, there are, each family has its own culture, cuisine, what to prepare, how much to buy. And remember that it's a family situation. We have to tell them, I'm not treating the child with obesity, I'm treating the whole family, even if other members of the family are not, do not suffer from overweight or have a healthy weight. Of course, anything when we evaluate body measurements, diet and physical activity, it should be performed at the baseline at specific intervals. Now, usually, again, when we're talking overweight and obesity with no secondary complications, we move to prolonged weight maintenance so that the child grows, and of course, with the growth, the prolonged weight maintenance would lead eventually to correction of the overweight or the obesity. If we are dealing with a child with overweight and obesity and secondary complications, we would recommend weight loss of 0.5 kilograms per month for that child, whether maybe adolescents can or teens can lose up to 1 kilogram per month. This is an issue in the clinic because we face, every time I explain this to parents, I face objections saying, what, only half a kilo a month? How come this is not, it's dangerous. I mean, it should not be the case. My child should lose maybe 2, 3, 4, 5 kilos a month. The doctor, the pediatrician told us that he needs to lose 10 kilos. Again, it's very important to have a dialogue with the pediatrician and see so that we have the same language with the parents and explain that a faster weight loss is not recommended for children, especially children under preteen children, so 6 to 7 years of age, or even 2 to 3 years of age, because we do face this in the clinic. Now, when we're talking about recommendations for the dietary approaches, no diet approach actually was the most successful on the long term. Studies looked at the low-calorie diet approach, studies which is, in other words, high protein, or now the most famous keto diets. They looked at high glycemic load diets. Most have shown, or the low carbohydrate diets, or the high carbohydrate load diets show that the child loses weight. It is successful compared to baseline at the end of the intervention. However, this is not sustained on the longer term. So the children or the teenagers, whether teenagers or children, gain back the weight on the long term. So the no diet approach, actually, even if it is also compared to a structured meal plan, showed that it is more successful because the children actually, or the teenagers, adhere to it and keep it on. So it's mostly around recommending low-fat, nutrient-dense foods with moderate portions, with no pre-prescribed caloric intake. When it comes to calories, it is, when we're talking about caloric needs, sometimes these can be lower than the children's needs to maintain their weight, but it should never be below 1,200 calories, and this is around 1,000 to 1,500 calories. Again, without actually providing, without telling or explaining about the calories, so that the child feels at ease with no restraints, with, of course, explaining about the importance of consuming low energy dense foods, of course, by increasing the intake of fruits and vegetables, and decreasing or minimizing sugar sweetened beverages and snacks, and, as I said previously, low fat dense foods. Now, again, those types of diets have shown, have shown that restrictive dieting is, so this is a very interesting study, if you have time to look it up, and that the strongest predictor of weight gain is dieting, and that is specifically true for young individuals, for youth. Actually, when we looked at weight gain or weight regain, restrictive dieting was causing weight regain in children, kids, and as well as binge eating. That was the same with teens, specifically with teens. Dieting or restrictive dieting led also to eating disorders. So this is something very important to note and to discuss also with parents, because actually some parents tend to ask or demand, between brackets, that the diet be restrictive so that the child loses weight quickly. When it comes to structured physical activity, again, it should be planned. I mean, within our lives, our hectic lives, if it's not planned, it doesn't happen. And we want it to be fun for children. Remember, not any physical activity is convenient to all children. Some children do not engage in physical activity because the type of sports is not convenient for them. If I have a child with obesity and I'm asking him to run for half an hour a day, that's not something that he would actually do. And this is what we actually see sometimes in the physical education sessions at schools, where it's a one-type-fit-all sports for all children, and we see dropouts or teenagers asking for permission to skip physical education because it's not something that they can do. It's not an excuse to say they don't like to exercise. It's not it. I'm sure we can find a type of exercise that fits the child and of course follow his or her preference, but also his ability to do it so that it is sustained over time. Again, another challenge is decreasing screen time to 2 hours a day. I don't know how this is possible. I know that during COVID-19 that was not at all possible. I remember we had issues with when we were, of course, teaching children or doing nutrition awareness online with schools. They had to do the program, our program, Ajal Salima, online. And we were trying to find ways to ask them to move while actually studying, doing activities or things that they have to do on screen because they cannot leave the house. And of course, again, we have to involve the whole family in the lifestyle changes through preparing meals at home. We actually, as dietitians, need to explain to them, give them healthy recipes, tell them that they have to eat as a family, healthy breakfast, healthy dinners, and very importantly, let the child self-regulate his or her meals. So being overly restrictive actually would feed, I would say, bad behaviors. In Arabic, we say كل شيء ممنوع مرغوب. So every time we tell the child, stop eating, it's enough, you had too much, then he would want to eat more, even though he or she would feel satisfied. So that's again a challenge to explain to parents. Again, we have to explain and tell parents that they have to be the good example. I had examples also at the clinic where the family or the mother has to prepare a certain types of food for the father who only eats fried food because he does not like fruits and vegetables and healthy cooked meals, and another type of meals for the children, and then the children wanting to eat like their father. So setting a good example is the key. Most importantly, as well as parents, is to foster a healthy relationship with food. So mothers who tend to be overly restricted about their diets, their weight, how they look, would tend to actually relay this to their children and lead to also some problems in dialogue. Now, when we're talking also dialogue, negative comments are a no-no. It's a big no-no. We can never use negative comments with children. The child is a star, however he is, whatever his weight is. So this should be clear to all family members, to all the community surrounding the child, and especially at schools. We have to talk with school principals, to nurses at the school, and explain to them about overweight children being bullied. Of course, we have talked a lot about choosing non-food rewards that starts early on, and prepare children for a lifetime of healthy habits. One quickly about getting enough sleep. That's also important, because studies have shown that children who do not get enough sleep have more risk of developing overweight or obesity. In case of severe obesity, pharmacotherapy, weight loss surgeries can be discussed, of course, with the pediatrician. I'm not going to go in details about pharmacotherapy. There are certain treatments and medication that can be prescribed for children with overweight and obesity, with comorbidities, of course, if the child has or suffers from, for example, type 2 diabetes. Weight loss surgeries have been looked at children with severe, again, obesity, but all these along with other approaches. And if weight loss surgeries are to be considered, there should be a preparation, several preparation steps to prepare the child and the family, and make sure that they understand the post-op steps of these surgeries, how important it is to follow, of course, certain dietary approaches to make sure that the child doesn't have any issues after the surgery. And before we start the case study, so we'll have to do work together on a case study, I want to encourage you, if you would want to actually stand up and do some exercises. Would you like to do this with me? To stretch a little bit? Yes? I'm looking at chat. Okay. Kim, do you think we can open the cameras so that we see how many of our participants would show us? Would you like to open your cameras so that we exercise?
Sure, Dr. Carla. Anyone who would like to participate over a camera, you can raise your hand and I can move you to the panel room.
Okay. So if you want to open your cameras, please raise your hands. Without camera, no worries. Okay, good. So if without camera, then those who would want with camera. Hi, Nagam.
Hello, Dr. Carla.
How are you?
I'm fine, thank you.
يلا أنا عم بزيح الكرسي كمان. I'm moving my chair. Ready? Are you all ready? So we're going to do a game that I usually do with the children at school. And this game is about actually writing the word coconut with our body. Ready? So we would start with the C and try to stretch as much as you can. Okay, then the O, and stretch your hands up. Then another C and stretch as much as you can. Another O. Then we go down for the N go down. If you need to open your legs, go ahead. U, back, and T. So now we're going to do it another time, a little bit faster. C, stretch. O, C, O, N, U, T. Again, faster. C, O, C, O, N, U, T. Two more times. C, O, C, O, N, U, T. Thank you. I think it took us a minute or less. So I encourage you to do this several times a day. So thank you, Dua. Amira, you liked it as well? Great, great. So that's how physical activity should be. It should be fun all the time. Otherwise, children will not do it, and we have to do it with them. Very importantly is to do it with them. So are you ready for the case study? It's very simple. It's just for us to actually, have some chats. So we're looking at Mona, who is an 11-year-old girl who comes to see her physician for health maintenance. Her parents noticed that she had gained weight a lot since last year. What she usually eats during the day is, so she has breakfast, cereals with milk, toast and jam, and juice. Then she has a snack at school, sandwich with a peanut butter and jam, with 2 cookies, juice or soft drinks, a healthy lunch, baked chicken, potatoes, green peas, and milk. And at dinner, she usually has scrambled eggs, toast, and milk again. With her physical examination, her weight was 69 kilograms, her height 162 centimeters, everything else was normal. Just few notes that Mona's mother works from 9 to 5. So Mona goes to her grandma directly after school. Then, of course, she's there, she does her homework, but then she watches TV or plays on the computer. She cannot go outside to play outside because her grandmother is not very young and cannot watch her. So from safety point of view, this is not possible. So the questions are, I think there are 6 or 7 questions. I'm going to read them to you. Then if you need me to go back to the previous page, we will. So how would you decide on the type or stage of intervention concerning Mona's case? Question 2, what is the type of intervention for Mona's case? Question 3, do you think that Mona has structured meals and snacks? And what can be done to improve her meal plan? Do you suggest any special tools that can help you as a clinician give appropriate recommendations for Mona and her family? What type of behavior modifications can be used to help Mona? What would be your advice concerning the frequency of office visits? And finally, how can Mona's parents help in her diet plan? Would you like me to go back to the previous pages? So we can have 5 minutes, Kim, to do the case study. We have time for 5 minutes.
Yes, sure, Dr. Carla.
If you need more time, just let me know. And of course, feel free to ask me your questions. I open the chat box. So questions 5, 6, 7. Yalla. So the type of, what type of behavior modification can be used with Mona? What would be your advice concerning the frequency of office visits, and how can Mona's parents help in her diet plan? The Ali, want to see the previous slides? For those who joined late, we have an activity now. I'm looking at nice, very good answers. I like Dr. Rula's answer. Okay, so let's start by giving. So I had good answers with relation to what to do. We're going to go through the questions, each one of the questions, and so firstly, it's very important to plot the BMI and see where Mona is. So when we look at the BMI Z scores, we see that Mona has a BMI of greater than +2. So according to you, this means that she is a child with overweight or obesity. What do you think? Oh yes, she is a child with obesity, exactly. So when we're talking a child with obesity, this would say that we need to help her, or we need to go through the dietary approach. But do we put her under strict diet control where she needs to lose weight, or help her into prolonged weight maintenance? Yes, so prolonged weight maintenance, exactly. That's one of the, again, problems that we face when we face with a child with an overweight or obesity, is trying to convince parents that it's okay if there is a prolonged weight maintenance, because actually prolonged weight maintenance means that the child is actually losing fat. Now, it is important as well not just to take the BMI, but also to take the waist circumference, because most of the time during monthly visits, the waist circumference actually decreases without the weight being changed. So as we said, Mona has a BMI above 2 SDs, so she is in stage 3. Intervention is recommended. Now, I have seen a lot of very nice suggestions, which of course all goes down to decreasing high energy dense snacks and drinks. So as you have noticed, Mona has a lot of, I would say, added sugars in her diet, whether through sweet drinks, juices, jam, although jam is okay. Now, in terms of protein, I have seen some comments where we have to increase her protein intake. Yes, sometimes protein foods such as peanut butter is not the perfect choice when we need to decrease the fat content without decreasing the portion. So actually, it's very important also to look at food sources of, let's say, high protein sources of food without having high fat content when we want to decrease fat content without jeopardizing the portion. We need to be able to recommend a sufficient amount of portions with, of course, moderating the size of the portion, but let the child feel comfortable. What are the tools that we can use? Always have, if you are teaching children and their families, have food portions to show, measuring cups. This has to be easy for parents to be able, and children to be able to quantify without, again, being restrictive. I know there are a lot of applications, and these are a lot used among youth, teenagers. Actually, I have a lot of teenagers, 14, 15, 16. So you use applications where they plot their food intake, and the application actually tells them how many calories a day. So we end up, every time they would end up telling me how many calories I should have a day, and then they plot in this application and control. I personally do not prefer this way because it is again restrictive, and those applications are not always very trustworthy. Also, depending on the databases, sometimes they don't have the actual food that we eat at home. Decreasing screen time, encouraging gradual daily physical activity is very important. And here again, when we encourage daily physical activity, it has to be, we have to sit with the parents and discuss what can be done. And they have to leave the office after having decided with you on a plan. As you decide for the nutrition plan, you have to decide for the physical activity plan. Don't let them go out and leave them on their own to decide what is better for their children. I would recommend monthly visits, but as Dr. Rula, I guess, said, we have to check with the child. Sometimes children don't want to come to see you every month. Sometimes they want to. Depends. I have those two types of patients. The young patients who do not want to see me every month, and those who actually insist on coming on monthly basis to check with me, ask me their questions, etc. And finally, for the answer 7, parents should definitely provide a healthy home environment with less food temptations. It's not that we do not want children to eat what they want, but again, we sometimes need to discuss the grocery list with parents and their purchasing habits. I had to deal sometimes with parents who buy sweet drinks in bulk, who buy chips in bulk, who buy cookies in bulk. So we needed to actually discuss these and find alternatives. We don't want the child to be restricted. We definitely don't want the child to stop consuming all foods that he or she likes, but it has to be better plans. Again, so that's it. I don't know if we have anything else. We can discuss it later on. But before we end the session, I would like to draw your attention. I don't know if you actually noticed, every time I was saying, obese or fat child, I used to correct myself and say a child with obesity instead of obese child. Actually, there is a typing mistake. So obese, fat, or unhealthy weight. No, there's no typing mistake. I'm sorry. So instead of saying obese, fat, weight problems, we should say unhealthy weight, body mass index. We should always refer to the child with obesity and not obese child. It's not like, it's not a definition. A child has obesity. It's like he has type 2 diabetes. Again, instead of saying you should not eat that, you should not do that, let's see if there is other choices. Even us as clinicians, we should use this language. And please, please, all of you students who are watching or participating today, during the presentations on childhood obesity, do not use offensive pictures of children with overweight. If you have noticed, I did not use any picture with an overweight child. Actually, there is the site maybe on WHO where there are certain the pictures if we want to illustrate children with obesity. So it's very important to be mindful about this even during our presentations. And finally, just to conclude, we all agree that childhood obesity is growing fast worldwide and it is preventable. There are a lot of new strategies and science-based guidelines to curb the growing evidence of childhood obesity, but I'm sure we can find new ones as well. Childhood obesity is dangerous because it can lead to obesity into adulthood and the development of non-communicable diseases at a very young age. And addressing childhood obesity is important to determine what anti-obesity therapies are needed or important. Restrictive dietary control is not recommended at all, specifically to avoid the risk of developing eating disorders. What is the optimal amount? This is still a big question mark of time that clinicians should allow before recommending more aggressive weight management strategies, such as anti-obesity medication or metabolic surgeries beyond lifestyle changes. And certainly prevention and treatment of pediatric obesity is not a one-person effort. It requires the effort of several entities, multidisciplinary healthcare team, parental involvement, and national policies. And I'll leave you these take-home messages from the Institute of Medicine, where it says that physical activity should be, or we should make physical activity an integral and routine part of our life. Food environments that give or ensure healthy food and beverages should be easy. It should not be something difficult. We have to market healthy messages about healthy nutrition and physical activity, expand the role of all healthcare providers for obesity prevention, and finally, make schools a national focal point for obesity prevention. Thank you all, and remember, instead of talking about childhood obesity to kids, get them, or about healthy lifestyle, get them involved in a healthy and active lifestyle. So getting involved is even better than actually just talking about it. So thank you all for your attention. Those are my social media pages if you would like to follow me. And those are the references. So thank you again for your attention. I think we have a short talk. I'm going to stop sharing my screen, or I stopped, right? I'm not sharing my screen anymore.
Yes, thank you so much, Dr. Carla. Attendees, please stay with us for the Q&A. For the moment, we have Mr. Zishan Ali from Specialized Beauty Spec Bright Group, who will present with us the product InBody, who is related to our topic for the day. Mr. Zishan, welcome to the webinar.
Hello, hi, Kim. My voice is clear. Can you hear me?
Yes, Mr. Zishan.
Okay. Shall I start?
Yes, please.
Okay. Well, thank you so much, Kim and Dr. Carla, for your presentation. So I'm very excited to share the in-body applications in child obesity. So actually, this is what Dr. Carla said about the consequences of child obesity. I want to discuss briefly. Like the more immediate health risks can be the high blood pressure, the increased risk of impaired glucose tolerance, breathing problems, joint problems, or fatty liver diseases. But what are the future health risks also can happen? You know, the obese children can carry the obesity when they become adult. So again, there is a high risk of several diseases like heart diseases, type 2 diabetes, and cancer. But also it has been seen that when the children they carry the obesity, and when they become adult, so those diseases becoming more severe. So this is always a matter of concern to look into the child obesity risks. Okay, so with the help of InBody, you can have the comprehensive assessment of child obesity. You can easily monitor the growth trends throughout the childhood and adolescence. Understanding the potential risk associated with obesity, you can create your personalized nutrition and exercise interventions to improve long-term youth health and outcomes. Here, I would like to share you a study which states that the BMI is a poor predictor of adiposity in children, especially why? Because the BMI can provide you the inaccurate assessment of body fat levels, particularly for the children, because it is based on weight, and it doesn't discriminate between the two components of weight, which are fat and lean mass. So which can vary substantially between the individuals with the same BMI. So it's always, you need to look when you see the BMI is higher. So you need to look separately the fat mass and lean mass, what makes the BMI higher. So here I can show you the picture of an iceberg. So BMI and weight is just like an iceberg. So you can have a preliminary information, but you cannot predict that how stronger or deep the iceberg is. So similar with the help of the BMI and weight, you cannot get the most body composition. So you need to look for the further details, what exactly your body is composed of and what makes the BMI and weight higher. Introducing you the in-body body composition analyzer, though there are various methods of determining the body analysis. Let's say like DEXA being the gold standard, measuring the body composition, but it is not really readily accessible, and especially for the young children, it is not recommended to do the test because of the excessive radiation can be harmful. There are some methods like air displacement procedures, which are also costly and not very comfortable. So what InBody can do is it can provide you the quick, easy to perform and comfortable for subjects. It can give you the accurate and capable of producing the reliable results accurately and consistently. With the help of the InBody result sheets, you can track down the growth charts. Okay, you can see if the children are growing properly with respect to their height and weight, and you can really see the muscle growth also, in case if there is a hormone treatment is provided to the short stature child. Also, I would like to share you another study. So there will be a lot of studies, and if someone is interested to have this into the real studies, I can share you later on after my presentation. So this study shows that the muscle mass is the most important predictor of the bone mineral content. And then the higher the muscle mass, the higher the bone mineral content. So this also suggests that the increase in muscle mass is an important factor for growth. So like all this information, how you can correlate with the in-body result sheet is like you can also monitor the percentage body fats to check the obesity status. You can check the muscle change, not the weight change. Okay, so if the weight is changing, so it's because of the muscles or the lean mass. And you can check the nutritional status of the child growth through the muscle fat analysis. Okay, so you can really track with the body composition history. You can really see the change in the weight with respect to its muscle mass or percentage body fats. Also, there is another study I'd like to share, which also states that the excessive body fats in the children can increase the insulin resistance and thus increase the risk of type 2 diabetes. So you can see all the tests being done over here, which shows that the higher the percentage body fats, there is a higher risk of high insulin resistance. Another study I would like to share also as a result of the body composition analysis of obese elementary school students with a family history of type 2 diabetes between the ages of 8 and 13 years. So it was found that the accumulation of visceral fats increases the risk of type 2 diabetes. From the in-body result sheets, you can see the BMI values, and you can guide your dietary recommendations based on the body composition, and you can track the improvement based on the muscle fat analysis. So this is very important, which I'll be explaining you in my next slide, how you can read out this muscle fat analysis, and you can put up your guide to the dietary recommendations. So it can give you the C, I, and D results. C states about the cautious, I is ideal, D is developed. If I consider only the C, so it shows that the muscles are lesser than the fats. It can result into sarcopenia or skin obese body, whereas the ideal has the balanced muscles and fats, normal and healthy body structure. So this one here, you can see the muscles is higher than the fat mass, which forms the D-shaped results. So this is mainly for the muscular or athlete people. So different body compositions need different types of nutrition and exercise interventions. So by knowing the exact body fat analysis, you can plan your dietary recommendations. Another childhood obesity challenge, it was conducted in one of the hospitals in US, where after reviewing all the body composition information about the children, um, the the doctors were easily able to convey that, okay, the same kids, is getting, your kid is getting stronger, and they have lost the body fats and they got taller as well. There can be improvements without seeing improvements on a regular scale. So by having the in-body result sheet, you can have more detailed information about the specific children, and you can elaborate the results more easily and predict the higher risk of diseases, and also can do the prevention accordingly. So I made a very quick presentation just to be in the time, but I'm available for any kind of questions, or if you wanted to if you all wanted to have the case studies as well. Thank you so much.
Thank you so much, Mr. Zishan, for that wonderful presentation. First of all, we would like to inquire if is it fine to share your presentation to the attendees, the one that you are showing now? Mr. Zishan?
Sorry, yes.
Yeah, the attendees would like to know if is it okay to access the presentation that you have shared today?
Yes, I will share you the presentation after this call, and you can share the presentation with them.
Okay. Also, there's a question, is it accurate for bodybuilder or pregnant women?
Okay, so first of all, in-body uses the BIX technology, which uses the microcurrents. It's completely safe to use with children, with pregnant ladies, with the bodybuilders also. Okay, but for the pregnant woman, because it has been reported that the possibility of gestational hypertension syndrome can be identified in advance by monitoring the trend of increase and decrease of body water measured in early pregnancy. So because of the water balances changes, so results won't be accurate at all the time, but it's completely safe to use with the pregnant women. But bodybuilder, it is best to use with them.
Thank you so much, Mr. Susan. Please stay with us for any further questions that is related with InBody. For the meantime, Dr. Carla, can we have you to address the Q&A?
Yes. I'm here.
All right. For the first question, Dr. Carla, what parameter is best one to predict obesity?
We now are relying on the BMI. That's for sure. And we also, at the same time, take the waist circumference as an additional tool for predicting obesity. Of course, as we have seen now, having the InBody, which I use also myself, is extremely helpful in the clinic to track the changes in body fat, especially in children when we don't see an actual change in weight, but using this type of tools can help us actually see the decrease in fat while the child is growing. So when the child grows, his muscle mass actually weighs. So on the scale, it doesn't show that he had lost weight because the muscle mass would have increased. But with the waist circumference or with the InBody machine, we can tell how much this has changed.
Thank you, Dr. Carla. Another question. What are the other parameters to measure apart from the body mass index?
So as I said earlier, the waist circumference and the InBody machine.
Thank you. What is your opinion about waist circumstances to predict the obesity?
We cannot actually only rely on waist circumference to predict obesity because there are still research that need to be done with the cutoff points. So now for the time being, the above 95th percentile would be a cutoff point that we are using now to say that a child with a waist circumference above the 90th percentile would be considered a child with obesity, but still there are a lot of, there are more science-based studies that need to be done.
Thank you. Is it more appropriate to use the CDC or the WHO growth chart in the MENA region?
I would actually use the WHO DMI charts for the MENA region, because the CDC charts are more towards the Latin America population.
Thank you. Are there any handouts regarding managing childhood obesity?
We have a lot of tools, a lot of handouts as well that we can find on many websites, especially the eTry.org website has many important tools that can be shared with health professionals, dietitians, nurses, etc. But of course, I always recommend that we do our own.
Right. What about morbid obesity?
Yes. Now, we would like to call it more as severe obesity or children with severe obesity, where in certain situations, we would need to rely not only on pharmacotherapy, or pharmacotherapy would be there to help in treating diseases, but surgeries or bariatric surgeries can be considered.
Okay. Is it helpful to explain to the child how to read the in-body, like we focus on muscles and fat loss other than weight alone? Because sometimes the child will get annoyed with his or her fat percentage increased again.
Exactly. It all depends on the child. Sometimes, sometimes you don't even take the weight of the child in the clinic because it is so, it might be demotivating, or it might raise concern when it comes to body image and in relation to eating disorders. So sometimes we just do measurements without showing anything to the child. So it depends on the child himself or herself in the clinic. See, you have to decide case by case.
All right, thank you, Dr. Carla. I just have 2 questions for specialized beauty. Mr. Sashan, at what age we can start using InBody for children?
Okay, from 3 years up to 19 years, you can have the child growth sheet. So minimum age is 3 years, and up to 18 to 19 years, you can do the test.
Right. A follow-up for that question: can they have the sheet for the child growth sheet for 3 up to 19 years?
Yes. So InBody gives you an option to choose the body composition for adults, then a separate child growth sheet for the children from 3 to 19 years. Once you select the age limit, you will get the separate child growth result sheet.
Thank you so much, Mr. Zishan.
I have a question for Mr. Zishan.
Yes, Dr. Carla.
Yes, sometimes we see on the charts a decrease in the muscle mass, the skeletal muscle mass, but this is not necessarily a decrease in on the actual muscle mass. It might be a loss of water, correct?
Okay, so actually, when you see the less in the muscle mass, actually you need to understand, when InBody measures, it gives the total body water amount inside the muscles. Okay, so when you see the total body water is the amount of water inside the muscles carrying, and when you see the decrease in the skeletal muscle mass, it also correlates directly to the total body water as well. But you need to see, as I said, like muscle fat analysis, so you need to really compare with respect to the percentage body fats also. Like if the weight is increasing, so it's because of the decrease in the skeletal muscles and increase in the fat mass, or decrease in the fat mass and increase in the muscle mass.
So can you differentiate, because it's a one reading, how can you differentiate when it is loss of water or loss of muscle mass? Because it doesn't show,
Okay.
when you have a decrease in muscle mass without decrease in total body water, it means that this is not water losses, it's muscle mass loss, correct?
Yeah, actually, when you see the InBody result sheet, so there is a body composition history. Okay, the body composition first sheet, where it shows you the total body water, then the proteins, the minerals, and body fat mass. Okay,
Yes.
so when you see this, So you can see the total body water. If total body water, there is a change in the total body water, you need to refer to the extracellular water ratio, because it's a sum of intracellular and extracellular water. So segmentally and separately, you can see the change in the total body water. But if there is a change in the skeletal muscle mass, you need to refer to the extracellular water ratio. If it's also changing, so it can affect the skeletal muscle mass as well.
Okay, thank you.
All right, Dr. Carla, just to address a few more last questions before we end.
Yes.
Is it hard not to measure weight because you need it for the documentation? How can we deal with that?
Actually, it is hard, but if this is what we have to do in order to engage the child, then we just don't take the measurements. It's okay. Whenever the child feels comfortable to step on a scale, then we do it. If the child is not comfortable, even if this would delay us a little bit in our to actually follow the progress of the child, we have to deal with it. Now, with time, the child would maybe accept to go on the scale. You can actually, this is a technique that I usually do. I ask the child not to look, especially when it comes to teenagers. I ask them not to look at the scale, to close their eyes if they don't want to see. And I also ask the parents to step outside the clinic, wait outside for me to take the measurements, so that no one actually would see or read the measurements except me. So this is working with me when we have children who do not want to weigh themselves.
All right, last question, Dr. Carla. How can we make sure that the weight loss is from fat, not from muscle mass?
Again, if we have access to the Embody machine, that's great. It's a great tool that can help us. I personally also rely at the same time on the waist circumference. So when you have a weight loss accompanied by a decrease in the waist circumference, that's definitely fat loss.
All right. Thank you so much, Dr. Carla, for a wonderful webinar. Before I end, would you like to add or comment anything?
I would like first to thank you, Kim, for an excellent organization. I would like to thank Dr. Aisha Dahiri, Dr. Layla Sheikh for hosting me for this webinar. I enjoyed it a lot. I always like to, share experiences and have encountered, even if virtually, colleagues in the field. So good luck to everyone, to all of you who are going to deal with this issue, and let's join efforts and help stop the rise of pediatric obesity in our region. Thank you again.
Thank you so much, Dr. Carla, for your time and for a wonderful presentation. We truly love to have you with us from the conference to webinars, and hopefully next year we would be able to see you personally here again.
Inshallah, inshallah, we'll meet face to face. Inshallah.
On behalf of the Chief Health Treatment Undertaking Services, Professor Aisha Al-Dahiri and Dr. Layla Sheikh Ismail, the Chair and Co-Chair of NHS 2021, we would like to once again thank all our attendees, Dr. Carla, for your time, for staying with us all throughout this time towards the weekend, and for our partner for today, Spec Bright Group, the InBody machine. Once again, please be reminded that our course attendance was monitored for the number of minutes that attendees who were connected to calculate the CME hours. He will be receiving, as part of the new Department of Health Abu Dhabi CME Certificate Attendance Issuance Guidelines. Please be reminded, everyone, that all residents of UAE are required to request your certificates through DOH TAM online portal, which you will receive the step-by-step process from us 24 hours after the webinar. Make sure that you will request the title of today's webinar, as the DOH will approve all the requests after we submit the attendee list. Furthermore, for the international attendees, we will be the one to send and provide you your certificate after complying with the required process, which everyone will receive through Zoom. We would like also to kindly invite everyone to follow us, like and subscribe to our social media accounts, Facebook, Twitter, Instagram, LinkedIn, and YouTube under the KIF account to receive the announcement of our upcoming courses, as well as view the previous recorded sessions following also our recorded session for today. With that, for those who are unable to join, we are also simultaneously live through our YouTube and Facebook account. Lastly, we would like also to take this opportunity to invite you all to join us with the KIF's New Normal Scientific event as we celebrate our 10th year anniversary on 2022. On January 21, 2022 in Dubai, we will be having a one-day workshop with not less than 6 CME hours titled Nutrition-Focused Physical Examination to be given by Ms. Carla Daoud, dietitian from Cleveland Clinic, Abu Dhabi. Also, the much-awaited one-day nutrition and health symposium with the theme Obesity Management with not less than 8 CME hours, along with our NHS 2022 Symposium Chair, Ms. Wapa Helmi Ayesh. After this webinar, all the registrations will be open through the KIF website. Hurry and book your seats now and avail our very minimal registration fee. Once again, everyone, thank you so much for your time and for staying with us all this late hour. And to our sponsor, Mr. Zashan, and to our speaker, Dr. Carla, thank you so much. And we wish you all a safe and enjoyable weekend.